again, Jared, thank you so much for joining us this morning. Hope and I heard Jared talk in California, and we were both like, "Oh, can you talk to our team too? We can't fly you to Hawaii, but Zoom is very cool." So I'm so glad that you agreed to talk to us. So I have a short bio for Jared. He is a Jared Rubenstein is a pediatric palliative care doctor and medical educator at Baylor College of Medicine and Texas Children's Hospital in Houston. He is passionate about helping people talk about difficult things and believes that the use of satire, animation, and humor can facilitate these conversations. When he's not talking about palliative care, he loves traveling, spending time in nature with his wonderful wife and two hilarious kids. Jared, thank you so much for joining us this morning.
Yeah, well, thanks so much for having me. I love talking about this, and so I think I'm happy to take questions and talk after. I love this topic, and I'm just honored that y'all asked me to come out and talk about it. So we're going to talk about palliative care PR, exploring new messaging strategies. Hoping by the end of this talk, we can kind of talk about where we're at with the current state of palliative care messaging, talk about some potential pitfalls of the way we do it and room for improvement, and then talk about future strategies of how we can do better. And hopefully we can all get a little angry. And we'll talk more about that in a bit. So I don't have anything to disclose. I do want to disclose that I know so much work has gone into this before now about thinking about messaging and how we sort of move our field forward. And I'm very mindful of the privilege I have to try to think differently about it because of all the progress and work that's been done before. And so speaking about before, we'll go to the beginning of palliative care. So Dr. Balfour Mount in 1974 coined the term palliative care. And in interviews, he said that he did this really to avoid the negative connotations with the word hospice. And so from the beginning, we've been in kind of a fraught space of thinking about the words we use and the way we talk about our field and talking about, not some of what we are, but also what we're not, and sort of thinking about the stigma and bias from the beginning. And then here's where we are currently. So palliative care is specialized medical care for people living with serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life, both for the patient and the family. Palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the patient's prognosis. It's appropriate at any age and any stage in a serious illness, and it can be provided alongside with curative treatment. And so that's from CAPC, the Center to Advance Palliative Care. And I want to say I love this definition, and I use this definition all the time. And yet we still know that about 70% of people don't know what palliative care is. Study in the bottom right was looking at just for adults' perceptions of palliative care and found that about 70% of people hadn't heard what it is. When they got told what it is, when they read that CAPC definition, most people thought it sounded pretty good. And then the study on top is a pediatric study for my world that was done at St. Jude's Hospital. So it was parents of children with cancer and children asking them the same questions. Have you heard of palliative care? Yes or no? And found that about 70% hadn't heard of it. And then when they read them that practice CAPC definition, they thought it sounded great. And what was cool about this study was that they took it even one little step further and said, also, we want to let you know palliative care teams take care of children at the end of life. Does that change your willingness to have the team involved early in your kid's cancer care? And some people got a little spooked by that and said, actually, that doesn't sound great. I maybe don't want to do that. But an even bigger percentage said, I hope we don't get there, but that feels really important. So I'd be willing to meet a team early in my child's care. Something we've suspected for a long time, those of us that do this work, but now there's data to support that when there are negative conceptions about palliative care, they often come from other healthcare professionals. This was a study by Camilla Zimmerman and her colleagues that asked sort of similar questions. Have you heard of palliative care? What do you think of it? And then for people that had negative biases towards it or negative connotations associated with it, they explored a little further and said, let's talk about what you've heard, where you've heard those things, and found that they were, for most people that had a negative conception, it was actually attributable to other healthcare workers that had talked to them about palliative care and passed along some stigma or negative bias. This is not research, but some anecdotal work we did on our team when we started 8 years ago and we were meeting new patients and families. We said to them, have you heard of palliative care? And has your team told you anything about our team? And if they said something really wild, we put it on the sheet. And so I remember I was talking to a family once and the patient's mother said, can you tell me, why does your team have a bad rap? And I said, what do you mean? And she said, well, I'm really enjoying talking to you, but the doctor that said they were consulting your team said, I'm going to call palliative care and I know they have a bad rap, but don't worry, it'll be okay. And I said, I think we have a bad rap because people say stuff like that. And then there was the one where I was told by a patient's family, they said, we're calling palliative care, but don't worry. I didn't know why I should be worried. And everyone knows the best way to make someone not worried is to tell them not to worry about something. And then one of my personal favorites is one that I saw in a note from an ICU doctor at our hospital that said, he wrote his whole note, and at the end of it said, and so I went to the family and I talked to them and I prayed with them and I told them not to be scared of palliative care. I'm not sure I've ever been set up for failure like that. And so this is, I think y'all know this from the work we all do, that we see this every day. We also hear and we're told all the time that palliative care has an image problem. This was from the Washington Post a few years ago, that in the pandemic era, the term palliative care is even more scary for some, so specialists want to rename it. And it's often, it strikes me that the people that tell us we have an image problem are probably the same people that are creating that image problem by conveying negative connotation to patients and families when they talk about our work. And so if this was a horror movie, we would say that the call's coming from inside the house. And so we'll talk more about that, but I wanted to pause for a minute and talk about my story, kind of how I came to this. And so I'm a pediatric palliative care doctor, but I actually wanted to be an advertiser and go into marketing before that. And that didn't pan out, and I became a pediatrician instead. But I've always kind of embraced the role of thinking about advertising and PR for hospital projects. So when we start a new project on my team, I'm always the one that makes the flyers or comes up with the slogans and names for things. And it's been sort of a fun way to have a little bit of creativity amidst my normal day of work. And hadn't really thought about doing anything official with it. But then one day came that consult request. I think it's a consult request y'all know about, the one where you're told, we want you to go see this patient, but maybe don't say you're palliative care, just say you're the pain team. Don't talk about anything scary. Don't take away hope, and also maybe consider changing the whole name of your field. And so I was coming back to my office after this visit, and I had the thought, it feels like if you were calling the fire department and then said, don't go talk about fire. And I had this vision of, getting a grant and making this big video to talk about this, and realized very quickly that was never going to happen. And so instead, I made a cartoon.
Hi. We got a call that this house is on fire. How can we be helpful? Well, house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
And so I made that video and I shared it on social media, and it went sort of palliative care viral. And I had never really anticipated doing this or anything like this, but I learned some lessons from it, which are that, starting with our daily frustrations or pain points can be a great starting point for education and advocacy efforts. And using humor, analogy, and multimedia combined to make powerful education and messaging tools. And wondered if there was opportunity for more. I hadn't really thought about it, but got some good encouragement from colleagues and thought, maybe there's other videos out there. And so I started thinking, if a picture's worth 1,000 words, maybe a video can be worth an entire manuscript count.
I don't want you to be scared, but I'd like to consult palliative care to see you. Why would I be scared? It's just that I know palliative care gets a bad reputation sometimes. Why do they have a bad reputation? It's not that, it's just, What's palliative care? Well, a palliative care team is an interdisciplinary group of people that can help be an extra layer of support for patients and families dealing with serious illness. They think of the patient as a whole person and can help with physical, emotional, and spiritual distress. They help prioritize quality of life and can assist with planning for the future. That sounds amazing. Why would I be scared of them? Well, I'm not scared. Are you?
And then got me thinking, maybe we don't have to be so serious all the time, and we can make teaching and talking about palliative care fun, and we can make memes like the kids do these days, and have other ways to kind of communicate the ideas and the biases around palliative care. And so then the question comes, what's next in palliative care messaging? And I think I've gotten to the point where I think we should stop messaging. I think we should really reconsider, are we getting too hyper-focused on the minutiae of messaging and branding and talking about, should we say we're like hospice? Should we not say we're like hospice? Should we have the wrinkled hands on top of each other? Should we not have the wrinkled hands on top of each other? Sort of all the different things that we've been so focused on over the last decade that don't really seem to be moving us any further along and to being able to take better care of people and more palliative care. I think we should stop engaging in conversations about whether we should change the name of our field. And I think we should stop assuming we need to justify our seat at the table and just sit at the table. And this is one of those where I'm mindful of, I know that there was very much a time where we had to justify our seat at the table. And in a lot of places, we still might be there. But I also can't help but wonder if continuing to do that sort of is reinforcing. And so wondering if there's a paradigm shift, what would it look like to change our PR and messaging within the healthcare community? Other healthcare teams and other services and specialties don't do this. We don't see ads for cardiology. We don't have cardiologists talking about, how should we talk about the heart to get people excited about cardiology? It would be silly for them to do that. And I'm wondering if it's silly for us to do that too. And is it self-defeating to continually justify our presence? Does it sort of contribute to that? I think a lot about this quote, what you permit, you promote, what you allow, you encourage, and what you condone, you own. Every time we engage in a conversation about the name of our field, or every time we act like we need to justify our existence, are we contributing to the continued second-class citizen nature of our field? And palliative care is great, and we've got the receipts. There's a robust body of literature supporting the benefits of palliative care. Most people don't know what palliative care is, and when they learn, they love it. And so this narrative that people are afraid of palliative care hasn't really been borne out in the literature. And now we know that negative conceptions of palliative care often are protected from other healthcare workers. The World Health Organization considers palliative care a human right. So isn't that enough? What more do we need to do to show the benefits of our amazing field? So I'm angry about this. And anyone that knows me knows I'm angry about this all the time. And so what I'm wondering is, what if we all got angry? What would that look like? And there's benefits to it. This was a New York Times article talking about a study where they showed that anger is more helpful at motivating people to overcome obstacles and meet their goals than a neutral emotional state. So let's all get angry together and come back to that fire department video. I've been making these videos for 5 years now, which I still kind of can't believe, and have 60 or 70 of them. And I think they keep getting better. And I've gotten to collaborate with people that I really admire and gotten better with the technology. But without fail, when people see my videos, they say, our favorite one's the fire department one. I feel so seen. That was the one that really sums up our field. And at heart, that's a video essentially that's about how frustrating it is to work in palliative care and have to have these conversations with healthcare workers all the time that don't get it. And so if that's when we all feel the most seen and most heard, let's name that and let's talk about that and let's harness that frustration. So we know that anti-palliative care bias among healthcare workers is real. And I can't help but wonder if this contributes some to clinician well-being and burnout. If you talk to anyone that works in palliative care, they say, the hardest part of the job isn't the patients and isn't the illness and dying. It's dealing with other healthcare workers that don't get it and continue to have bias towards us. So let's talk about that. And since we're better at advocating for other people than ourselves, I wonder how many patients are needlessly suffering because of this. I think it's a lot. And so where do we go from here? I think we shouldn't spend one more second wasting our time on strategies that aren't leading to better healthcare for people. And so in terms of what comes next, I think there's really sort of two arms to this next stage. It's what I think of as kind of direct to consumer education and advertising, and the clinician education and accountability piece. And so for the direct-to-consumer part, there's this quote by Atul Gawande once he learned about palliative care that said, if palliative care was a drug, the FDA would approve it. And so I got to wonder, what would that look like?
Since starting treatment, I've had pain in my fingers and toes. Can anything help? Have you tried Palliative? Healthcare for my chronic illness has gotten so complicated. I wish something could help me navigate all my options. What about Palliative?
I know there isn't a cure for my mother. I just wish something could help us make the most of her last days.
Have you considered Palliative? Okay, so what's this Palliative I keep hearing about?
Palliative is a treatment available to anyone with a serious or life-threatening illness. It can help with pain and other symptoms, planning for the future, making difficult decisions, and caring for you and your loved ones at the end of life. Side effects include increased comfort, having your wishes honored, less depression, less spiritual distress, and improved quality of life.
Palliative.
And along the lines of direct-to-consumer stuff, I think there's a lot of people out there doing really good work on this. So there's Dr. Ciencio and Dr. Sammy Winemaker in Ontario have their podcast, The Waiting Room Revolution, and subsequent book talking about, how to get palliative care principles out into the community and really increase the level of primary palliative care. There's the NWELL conference in California, really trying to sort of bring palliative care to Hollywood and sort of engage with how we talk about this with the media. There's folks like my friend Matt Tyler, who's got his How to Train Your Doctor YouTube and Instagram channel that really talks about, how do you talk to your doctor about engaging in palliative care and bringing palliative care principles to your care? There's organizations like yours that are doing this and really continuing the conversation and getting the word out about palliative care to the general public. Then I think a lot about clinician education and accountability. And while I see a lot of really good work happening in the direct-to-consumer part, this is the part I don't see happening as much. And I think it's really important. And so when I think about that, I think, what does it look like on the state and national level? What does it look like on the institutional level? And what does it look like on the individual level? And so on the state and national level, I think it's advocating for policy. And Jeanette, you were just talking about the amazing work y'all are doing with this. So having a state pulse guideline and really working with your insurance companies and the government to have primary palliative care and subspecialty palliative care standards and increased utilization. And what would it look like to have this on a more national scale? I think the stuff like NHPCO and CAPC are doing this. And then, like I mentioned, your amazing organization is clearly doing this. And I think I would love if we in Texas had an organization like y'all's that was doing this kind of work, because we do not. I think looking at illness-specific models of it. So this is from the Cystic Fibrosis Foundation, and that on the website actually has different criteria for primary palliative care and subspecialty palliative care and names. If you have cystic fibrosis, this is the care you should be getting. You should be getting both primary and subspecialty palliative care and letting people know how to advocate for it. Then when you look at the institutional level, I think it's about sort of taking those national and statewide standards and putting them into practice. And so firstly, I think it's about increasing education and training at all levels. There's clearly not enough education and training at least in medical, in physician training and medical school or residencies, but I suspect it's the same for nursing and all of the other medical fields, that there's not enough education around palliative care. And then what would it look like to put those guidelines into practice? And so if you've got illness organizations like the CF Foundation, if you've got government policies that say everyone should have primary and subspecialty palliative care, all our institutions have standards of practice committees that this is their role. And while palliative care people are never going to be able to be in every room where patient care happens, maybe we can get ourselves into all the rooms where these decisions happen and where institutional guidelines are created. And what would it look like to develop local standards for palliative care, both at the primary level and subspecialty level, and utilize existing mechanisms to ensure accountability? What would it look like to have palliative care sentinel events? Like if all hospitals have a process, if somebody gets a wrong side surgery, all the bells go off, and that's a big deal, and it's a sentinel event, and there's processes to make sure that never happens. What would it look like to have similar processes to make sure that anyone that's dying in the hospital has aggressive active symptom management to make sure that they're not dying with pain and other uncontrolled symptoms? And what would it look like to be able to use institutional mechanisms to leverage that? And if there's a report that it happened, go through all the same processes as other sentinel events. And then when we're thinking about primary and subspecialty palliative care, if primary is the general competence in palliative care that all clinicians should have, and subspecialty is what we all do, the subspecialty expert level of primary or palliative care with extra training, what would it look like to have institutional guidelines around both those? And what would we do when clinicians lack education and training in basic palliative care skills, the same way we do with other fields? And how would we make sure that we're sort of being part of the upskilling people and mandating the requirement of those skills? And what if we treated a delayed or absent referral to palliative care the same way we consider other lapses in standard of care? I think there's still the sense that for palliative care, if it's not provided, it's just unfortunate. Or, we hear, oh yeah, this one doctor never consults palliative care, but that's just how she is. She just takes care of her patients really closely and doesn't like to have other people involved. And that's just her practice style. And I think we have to move past sort of that it's an allowable difference in practice and that it's just unfortunate to naming that it's wrong. If palliative care is a standard of care, it's wrong if people don't get it, whether it's from their primary medical team or from a subspecialty team. People deserve and need it. And it's been established as a standard of care. So what would it look like to enforce it? I think there's a lot of room for doing that. And then I loved hearing that this is such an interprofessional group today. So we should definitely be collaborating across disciplines with this. Efforts to adjust messaging historically have skewed towards medical providers, but anyone can consult palliative care, anyone can talk about palliative care. And so we should be focusing on interprofessional messaging. And also within messaging about palliative care, message about, what our roles are and where the magic of palliative care comes from in that interprofessional work, helping people realize, what the benefits of that are and how all our different roles work together. And so I won't show all these today, but they're all on my YouTube channel for anyone who's curious. It's a video called Get the Tissues with one of my social work colleagues we made talking about palliative care social work, valuable resources talking about palliative care nursing, and Hold Hands and Pray talking about palliative care, chaplaincy, and spiritual care. I think there's also a lot of room for us to have collaborations with patients and people that receive palliative care. There's a good friend of mine, Liz Salmi. This is her website on the right, Bringing Punk Rock to Healthcare. She's some woman that started her career as a drummer in a punk rock band, became interested in communications and healthcare communications, and then herself was diagnosed with a brain tumor and has then done work over the last 10 years or so in being a patient advocate and talking about how we can better engage with palliative care from the patient perspective. And she reached out to me after she'd seen some of my videos online and asked if I'd ever thought about collaborating with a patient or making patient-facing videos. And I said, I would love to. And also, here's some videos I've made that are patient-facing. And she very kindly but firmly, after she watched them, said, actually, those aren't patient-facing, and helped me realize that, I was so in it as a doctor, I didn't know what it meant anymore to be patient-facing, and I wasn't able to put myself in the patient's shoes. And having a collaboration with her over the last 5 years has been incredible, that we sort of both can inform each other's work and tap each other's expertise as we work within our own fields. And she actually coined a term for this that we wrote about a piece together, how to cultivate a friendship. So she defined friendship as someone you're friends with that's kind of a peer mentor in a different field, and you can talk to each other and pick each other's brain and collaborate on projects, each bringing your unique expertise to make the project better. And this is one of the videos we made together.
Hey, what happened in here?
Ever since I got diagnosed with cancer, I just feel like I'm totally in the dark.
I'm so sorry.
The different treatment options, all the side effects, worrying they won't work. I feel so lost.
Have you asked to see the palliative care team?
What's that?
Palliative care teams are groups of doctors, nurses, social workers, chaplains, and other healthcare professionals that work as a team to help patients and their loved ones get the best care possible.
Wow, really? Who is it for?
Palliative care is for anyone facing a serious illness. We focus on pain and other symptoms as well as emotions and fears about your illness in order to maximize your quality of life.
I think I could really use that.
Why don't you start by telling me about yourself and what is most important to you right now?
Okay, I'd really like that.
And so you may be thinking to yourself, I'm not someone who engages in policy on the state or national level, and I don't have institutional levers to pull. So last, I want to talk about what we can all do as individuals. And so for this, I think on the individual level of what I call reframes and pushbacks. So, in our work, we reframe the serious illness conversation all the time. We're master reframers. What would it look like to turn those reframing skills to our work? And are we allowed to push back? We're all nice in palliative care, and that's sort of the reputation of our field, that we're all sweet and nice. And maybe we should stop being so sweet and nice. Maybe we should, when we're talking about advocating for ourselves and our field and our patients, maybe we should be pushing back when we see anti-palliative care bias. And so the I like you, but this is one that I started thinking about. It was in the early days of our team here, maybe 8 years ago. And I was seeing a patient in the pediatric oncology clinic. And one of the oncologists said to me, "Oh, hey, Jared, I really like you, but it makes me sad when I see you here because I know it means somebody's having a really bad day." And I said, "I hate to break it to you. You work in a clinic for children with cancer. I think everyone here is having a bad day, but I'm actually here to try to make one of their days better." And he said, "Oh, when you say it like that, it feels different." And I said, "Yeah, that's why I say it like that." And then this one we hear all the time: "I wish nobody needed palliative care." And I think that's such a weird framing. It frames palliative care in an inherently negative light. I wish nobody had cancer. I wish nobody had heart disease. I wish nobody had rare genetic conditions. But palliative care is amazing. I love that people have palliative care, and I wish nobody had a serious illness, but I hope if they do, that they have access to palliative care, because everyone with a serious illness deserves access to interprofessional palliative care. This one we hear all the time: people are afraid of palliative care. we have to be careful when we introduce your team since people are afraid of palliative care. And I heard this one a couple of weeks ago. I was seeing patients on the oncology unit, and one of the oncology teams came up to our team and said, can we tell you about a patient? We're not sure if we want to consult you or not, but we'll just tell you the story and then we can talk about it. And so they tell us the story, and then they say, we hadn't wanted to bring up palliative care yet because, we don't want to send the wrong message. And I said, well, what message is that? And then they get a little nervous, and I say, I'll ask, like, when you say you're going to ask them if they want a palliative care consult, do you ask people if they want a cardiology consult? Do you ask them if they want a pulmonary consult? We should just talk about that you're going to recommend it. And one of the oncologists said, you're blowing my mind right now. Like, this is amazing. You're right. I do talk about palliative care differently with my patients than other specialties. And I said, it's not just you, it's everyone. It's a problem. And he was like, do other people know this? And I said, yeah, I think some people know this. And he said, do you want to come talk to our whole oncology division about it? And I said, sir, I would love that more than anything. And that was the best day of my life. And I thought about retiring just then so I could go out on a high note, but I got to pay the bills. So I'm going to keep working. But people ask all the time, how should we tell a family about, or a patient about palliative care? And I say, just like you do for other fields, you don't ask, you recommend. You say, I'm going to recommend we call the palliative care team. And then step 2 is you say why, just like you do for any other specialty. I'm going to consult palliative care because I think they'll be really helpful at managing your pain, or I'm going to consult palliative care because I think they can help you plan for the future and your illness really well. And then step 3 is you turn around and you walk out of the room before your own insecurities wreck it. And you say something weird like, don't be scared, or I know they have a bad rap, but don't worry, it'll be okay. I hear this one a lot when we work with our solid organ transplant teams, the transplant or palliative care dichotomy. They say they're talking to families and say, we want to talk about if you want a heart transplant or you want to go on palliative care, which makes it seem real ominous and seems like it's a choice to just get your plugs pulled. And so I'll push back and say, let's be clear. The opposite of a heart transplant isn't palliative care. The opposite of a transplant is not transplant. And people can have a palliative care on whichever path they choose. And I think helping people kind of find their own footing in their words to have these conversations. And then the last one, that you should change the name of our field. And I'll let the video speak for itself on that one.
Hi. I'm one of the new oncologists here. Good to meet you. But a lot of people find oncology pretty scary. Have you considered changing the name of your field to lumps and bumps? You'll get more consults.
Thanks so much for seeing my patient with heart failure.
My pleasure. But yikes, heart failure. I'm not sure the family is ready to hear that. Maybe just say cardiovascularly challenged.
What?
Hello. What brings you to Geriatrics Clinic? I'm here to see one of your patients. And have you thought about changing the name of your clinic? Geriatrics sounds so old, and nothing scares people like aging. What? Who do you think you are? You know exactly who I am. Say my name. I don't know what you're talking about. I'm the communicator. I'm the one who has the talks you don't want to have. I'm the one who makes sure that patient care is goal concordant. I manage pain and ensure dignity at all stages of serious illness. Now, say my name. You're palliative care. You're damn right.
Speaking of bingeable shows, that was my Breaking Bad tribute. And so I wanted to have a call to action. So I want us to all be proudly palliative and not be ashamed of our field or our name and not tolerate conversations about that. I want us to embrace the reframe and lean into the pushback when we're talking to other people about palliative care. I want to create standards of care and stick to them and work with our institutions to have enforceable mechanisms for ensuring that everyone gets the palliative care they deserve. I want us to continue the amazing policy work that y'all are already doing. And I want us to collaborate and work together because we do our best work as a team. And lastly, I want us all to tell our palliative care stories. So as you've seen from my stuff so far, my social media engagement has been very limited to me hiding behind cartoon people and robotic voices. And for this last part, I figured I would push my own boundaries and get over my own fear of the camera and discomfort with my own voice and make a video of myself.
Hi, I'm Jared Rubenstein. I'm a pediatric palliative care doctor and a medical educator. I love talking about palliative care. There's still not enough people out there that understand it, and there's still a lot of misconception about our field. So I wanted to tell my own palliative care story. When my team and I meet people, we see them as whole people, and we learn about their hopes, fears, values, and priorities so that we can make sure the medical care they get is right for them. We're a partner in their illness journey to try to just make each day a little bit better than it would be otherwise. It doesn't have to be any more complicated than that. Have you had an experience with palliative care? I'd love to hear your story. Are you a healthcare worker in palliative care? I want to hear from you too. Post a video of your own with the hashtag #MyPalliativeCareStory and tag a friend.
So if anyone's willing, that'll be my challenge for today. I would love y'all to go on social media to whatever degree you're comfortable and tell your own palliative care story. And here's the references, and then I'm happy to take questions.
That was so great, Jared. Thank you. I remember why we were so excited to invite you to come and talk.
Thank you.
Yes, you're right. Oftentimes we laugh in palliative care, but we, and using satire and humor. Again, thank you so much for this presentation, and I look forward to people's comments or questions in the chat. Well, I will certainly defer to Daniel Fishberg. Daniel has his hand raised.
Thank you so much, Dr. Rubenstein. It was really very enjoyable.
Thank you.
My neck hurts a little bit from nodding so much in agreement. Really so spot on. Jeanette has shared some of your videos earlier, but some of the ones, they're all great, and some of the newer ones were fantastic. One of the things I wanted to ask you about, I was really intrigued. Some of the suggestions, maybe whether they're pie in the sky, but palliative care sentinel events. I really love that concept. Do you know it? Is anybody at your institution or nationally? Have you been seeing any work being done about that? Or again, that the delayed or absent palliative care referrals as just substandard care, and really sort of turning the tables, really. Any actual work and practicality you're seeing being?
Not that I'm aware of, but I would love to partner or hear about it or see what's possible. I mean, I think you're right. I think they are pie in the sky, and I think that's why they're important. I mean, I think one of the stories I think about all the time, and one of my inspirations in culture change work, I always talk about the story of Takeru Kobayashi, the hot dog eating champion. I don't know if y'all know his story, but he came on the scene in around 2001. So I grew up in New York, and in New York every summer there's the Nathan's hot dog eating contest. And so people come, it's like a celebration of gluttony on the 4th of July, and they eat a bunch of hot dogs. And for the whole existence of the contest for the first 20 years, the winner would always eat between 15 and 20 hot dogs. And it created the assumption that 20 hot dogs was the most a human person could hold in their stomach. And all of the winners and competitors were the people you would imagine in a hot dog eating contest. They were big, they loved eating. And then in 2001, this guy, Takeru Kobayashi, comes on the scene. He was a scrawny guy from Japan that he was sort of credited with making competitive eating a sport and started taking it seriously in training and had his whole training regimen for it. But and so he showed up in New York and he ate 54 hot dogs and just like totally blew away the previous record. And it was amazing, but that's not my favorite part of the story. My favorite part of the story is what happened next, which is that he's no longer the champion. And now other people win, and other people routinely eat upwards of 50 hot dogs. And so it wasn't just that he was an incredible eater or that he had some body that nobody else has. It was just that he was the first one that had a pie in the sky idea and imagined what was possible. And I think we're always so hamstrung by what is that and how that frames our idea of what's possible. And so I always call on people to take his example of like, we have no idea what's possible. And we're so bad at deciding what's possible because we always just think about what is. And if someone can come and eat 54 hot dogs, I think we can probably get palliative care standards of care and sentinel events.
Yeah. So Jack Lewin here, thank you very much for your presentation today. It was really inspiring. I want to think back to a time when CTAC was being formed. I was the CEO of the American College of Cardiology, Nancy Brown, CEO of American Heart Association, and we recognized around heart failure in particular for our constituencies that we needed some new way to approach the care of people in that regard. But I think one thing that what I have to say about it is that I think the progress made since then has been astounding. From nothing to where we are today, where in Hawaii now we have a Medicaid palliative care benefit, first in the country.
Yeah,
So it's pretty fantastic. I think one feature of palliative care that we need to emphasize, which is a slight element of hope in there, is that there are people that emerge from palliative care and have grateful for what the terrible journey that they might have taken alone without the help of palliative care and support. So I think when you keep that picture in there a little bit, and make people aware that sometimes palliative care is necessary for a short period of time, that people emerge from it. That's also a positive thing, and we just need to keep that in mind as we discuss it. Thank you very much.
Absolutely. Yeah. And I mean, I think Jimmy Carter on hospice has been such a great poster. Boy, doesn't feel right for a 100-year-old, but poster person for that, you can be on hospice for a year and he's there and he's thriving and he's doing stuff. And I think it's sort of being such a public figure and having that on the national stage, I think has been great.
Terrific. Yeah.
Yeah, I think the concept of a tipping point, I remember a few years ago, there were these questions of what would be the tipping point to get people to actually understand more about what we do. So thank you, Dr. Lewin. I'm really interested in this systemic thing. So Dr. Fishberg started that with the Sentinel event. And actually one of the, someone made the comment that oftentimes these referrals are so late. And I'm always hesitant to have what happens if you give people incentives for certain things, and it usually goes badly. But from a policy, as you said, I mean, here we are, as our group, we've been around for a long time. We know lots of people. We're really interested in policy. Have you seen other examples that I was like, we say cockroaching, which means to steal. Have you seen groups that are doing this that we can learn from?
I haven't really. I mean, I think hearing y'all's organization, it sounds like has made progress that no other state has been able to. I mean, I think you're the example to some extent. I think no. I mean, I think it's not happening, and I think it's hard to have. I think it can go too like I think sometimes when I talk about this, people say, "Oh, you mean trigger consults?" And like everyone with X disease gets it. And I think there's places that have chosen that model, but I don't think that has to be the answer. I mean, when I think about it, I think like coming back to the example of cardiology that we've been talking about, in pediatric cardiology, there were in pediatrics there didn't used to be cardiologists, that were just pediatricians, and every kid with a heart disease got managed by their general pediatrician. And then pediatric cardiologists came on the scene, and pediatricians said, "Great, every kid with a heart murmur now goes to the cardiologist." And then pediatric cardiologists had to swing the pendulum back and say, here's what I want you to be able to manage as a general pediatrician. Here's the murmurs I want you to be able to recognize, and here's what I want you to send to me. And so there's a framework, and then there's sort of allowable individual variability. So there's some pediatricians that still send every kid with a heart murmur to the cardiologist. And that's probably annoying for cardiologists, but it's not necessarily wrong. But if there was someone that as a general pediatrician was trying to manage single ventricle heart disease on their own, that would be wrong. And that would be so against the standard of care. So I think we don't need trigger consults to have sort of implementable and understood standards of care. I think another sort of cautionary tale is what happened with advanced care planning, where a billing procedure was created for it. It was told everyone has to do it. And then it became this checkbox thing that nurses would ask when patients are checking into the hospital, like, where do you live? What's your address? Do you have a religion? Do you have an advance directive? And it becomes so rote that it's sort of effectively worthless. And I think having a way to have standards, but in a way that's not worthless and not sort of made just a checkbox, but something that is like actually leads to better care. And I think that's
Right.
that's the hard part. And I know all this stuff I'm saying is so much easier said than done. But I feel like at least saying it's the first step, and then people who are better at the done part than me, and the people that have the levers of policy and can do these things can start working on it.
Yeah. Yeah, and maybe we can find one group that wants to work on it and have a pilot and see how that might work. But I totally agree. And actually the advanced care planning is sort of that's why I said I watch how that doesn't work. And we fortunately have an advanced care planning, not only Hope, who's our coordinator, but these ambassadors who go out, and we basically do 2 sessions with people to break the ice and get people going. And then you see real results, but passing out a form, asking, I remember years ago, it's like, don't ask if you have an advance directive, ask where is your advance directive. If we get one question, let's just do that. So again, just having the algorithm, and it's interesting, Anita Jewell made that comment too, that the PCP is waiting for the specialist thinks it should be the PCP thing. We have a nice, like a simple assessment form that actually seems to work really well, that people can check a couple of boxes and start thinking a little bit differently about their patients. Again, we're hoping, Jared, with this new palliative care benefit. So to be clear, this is the first time CMS has defined palliative care. Until now, you could say, oh, my nurse will call you on a Tuesday, and that could be palliative care. But now we have like a very robust benefit. So we're in this good position of saying, wait, here's the team, and they can come and talk to you. And so we're in this interesting position, which is why, it's exciting to think from a policy perspective. Okay, we won't say
Yeah,
messaging, but
that sounds amazing.
the good thing too is that it's actually in the preventative space. So you can get like, our ideal is at any time in the disease, you can have a consult. But until now that hasn't been available. So this benefit actually can be in the prevention space.
Yeah, that's fantastic.
So one of the discussions that's going on in the chat is around community health workers, and I'm wondering if you've seen other places where palliative care has incorporated community health workers in to their practice, because that's something I personally am very excited about.
Yeah, no, it sounds amazing, and I have not heard of it happening before.
Okay, shoots, then we have to lead the way again. Because we certainly find in our very multicultural, many languages spoken, all of that, we really need folks who come from the community to do that. Years ago, one of my friends said, I think we can teach, like Marshallese community health workers about palliative care much faster than if we were to learn Marshallese. So using those
yeah.
folks, it's very exciting, those things that are happening. So
Yeah, I mean, I think that's such a great example because, when we have like hearts are the same in every country and every culture, lungs are the same in every country and every culture, but palliative care is not. And I think sort of our field's done a nice job over the last small handful of years of acknowledging that and sort of getting to the roots of, a lot of what we talk about in palliative care and how we communicate around serious illness is kind of a white Eurocentric model of doing it, and that's not going to be right for everyone. And I think partnering with community healthcare workers to figure out what palliative care looks like in non-white, non-Eurocentric communities, I think is huge.
Yeah, because we in Hawaii, we're a bit different. Didn't have funds to fly you out here and show you that we're not so white Eurocentric. But yeah, for us, the concept of talk story is really important, and building trust with people. So, a 7-minute visit is really hard for people to do. And so the next question too is, how can we use your videos? How have you used them in training? Can we link to them on our website? I mean, I can see people using these things. So how does it work?
Yeah, so yeah, I just saw the question that can it be shared? Absolutely. It's all on my YouTube channel. It's all public domain stuff, so you can post them anywhere. I use them for a bunch of different things. So I use them for in talks like this. I use them just as sort of standalones to post on social media to kind of try to have conversations around this stuff. Some of my favorite ones are actually using them in individual conversations. So in like the one I made most recently is a collaboration with a British palliative care doctor, Catherine Mannix, and the tagline is "Palliative Care, don't make it weird." And it's about how people make it weird when they have these conversations. And so I've actually shown that one just talking to other doctors when they're having this question, how should I call palliative care? And I like them because they're all a minute or two. And so I can just take my phone out and show it. I think one of the most impactful ones I used it for was actually I was working one weekend, and I was talking to the oncology team, and they were getting ready to go have a conversation with a child and their family about withholding food and nutrition at the end of life. And they weren't sure how to have that conversation. And I said, I'll go in there with you, but let's talk about it and I'll prep you and we can go have it together. And as part of the prep, I actually showed them the 2-minute food for thought video that's sort of about naming all the challenges and the emotional burden of having a conversation about withholding food and nutrition at the end of life. And we watched that video together and then kind of debriefed it and talked about it and talked the fellow through how to have that conversation. And then we went together and the fellow had the whole conversation and led it and did a fantastic job. And so I think using them for sort of just-in-time teaching has been something that I've really enjoyed doing as well.
Yeah, that's really interesting. So another part of the chat was at our medical school, we actually do have a rotation. So we can also be making them aware, and Dr. Fishberg teaches some of those students, but I should say many, all kinds of people do. So thinking about how we can integrate them in. And I totally appreciate the humor and the satire and just shaking people up is really it's good. So I'm also thinking, I'm assuming you do like grand rounds, you do other kinds of things.
I mean, honestly, I'm kind of new to this. I go wherever I'm
Oh,
invited, but it's only been over the last sort of 6 months or so that I've been getting invited to come talk about this. So I would love to give grand rounds. I'd love to talk wherever.
mm,
But I think yeah, I mean, and I think getting it's one of those things that probably the people that need to hear this are not the people that would on purpose seek out the information.
right.
And so sort of how to get in front of general audiences that will be captive and have to listen to it whether they like it or not, but also moving very upstream. And so going in, because again, as much as I love all the direct to consumer marketing, I think no matter how excited you get the public about palliative care, if they show up at their doctor's office and say, I just heard about this thing that's palliative care, can I get it? And the doctor says, oh no, you're not there yet. You don't need it. It's over.
Right.
And
Right.
so I think while it's still a gate kept consultant specialty, having ways to get involved and sort of embedded in education upstream at the medical school level, at the residency level, doing things to really change the culture. And I think one of the things that I've been sort of most heartened by is seeing how excited the next generation of doctors has been about this. I remember the cardiology fellows at our hospital asked me to come give a talk to them, and then I got an email the day before saying, "Oh, actually, a bunch of our fellows are going to be out at another conference. Can we reschedule this because everyone wants to come?" And so I went and I said, I'm happy to reschedule. And so I went when it came time for the actual talk. I said, I love that y'all wanted to reschedule so you could all be here. I'm touched that y'all wanted to learn about this. And they said, we all know we need to learn about this, and we know that our attendings can't teach us this. And so I think that was really powerful to see that at least the next generation of trainees feels that this is a much more integral part of their education and knows that from their teachers and seniors in their own specialties that they were never received this training and can't teach it to them.
Right. Yeah, no, I find too younger people understand that, and it's which is good, and how we can make this more so, small groups where you can make inroads, who's interested. And we do have lots of things going on here, and I can see that, different approaches work for different people, and how they can start thinking about it. I just, back to where we were with the automatic palliative care consult. It's sort of, and like with the chaplain, do you want to see a chaplain? No one does. But
Mhm.
if we have a fabulous chaplain over at Castle who did a great presentation, and she said, I go by and we talk about the cats and the dogs, and then it moves into other things that are important, how we make it more standardized, how we make it part of what we do. I think that's really exciting to think about.
Yeah.
And so I wanted to address one thing in the chat, which Martha was asking about CHWs, because in our new benefit, CHWs are one of the groups that can be paid. So just wait, Martha, we're figuring this out. And the reason that it took so long to get approved is there's all these great things in there of beyond the team of doctor, nurse, social worker, chaplain, there's now community health workers who can be paid for their work, and a number of other things as well. So this new benefit, again, I'm so glad, like, this is one of the tools we can use. We're thinking about other things of how we can help both the providers and the public understand what palliative care is. So hopefully we can, get the enthusiasm going and make it just normal, and not make it weird.
That's the
Yeah,
idea.
so I wrote down a bunch yesterday. Was trying to do my homework and wrote down a bunch of your taglines. So I think we could come up with a whole t-shirt series of the what did you say, palliative care, don't make it weird, forget your agenda, we need to meet people where they are. I liked be kind to your colleagues, this work is hard. So there were a bunch of great taglines that you came up with. Can we try and use those too?
Thanks. Yeah, you're welcome to use any of it.
Good. What was the other one I liked? We may not always say what we think we said. I thought
Yeah,
that was, yeah, because I don't know how many times people say, oh, I told the family, and the family's like, no one told me anything, right?
yeah.
So there was another question somebody had. How do you make these things?
Oh, it's really, I'm not at all tech savvy. It's just actually a
Uh-huh.
phone app called Plotagon, Plotagon, and it's super user friendly. Anyone can do it. You just download the app and then you can create characters and then you just type in the text and the program makes the dialogue.
Because I was thinking, ooh, could we do it with a local accent, but probably not.
Yeah, there's robotic, they're all robotic. There's packages for like there's like a British accent package, but that's the only other one I've seen.
Right. Okay.
You
Good.
can
Well,
actually though, you can do it with your own voice. I've just never wanted to do that because I don't love my voice. But you can, instead of having the computer talk, you can click a button and record into it. And so you could
mm.
make it like you could make it a real person's voice.
Oh, you can.
Hmm.
Oh, well, then we can do it as a
Yeah, that's what I'm
local
saying.
version.
You can record a person's voice on it and do it like that.
Okay, we'll get Hope to do it in Pigeon, and then we'll see what happens.
Mhm.
We always notice if somebody's from here or not, so it's kind of one of those, it's like wearing a sweater. If someone has a sweater on, no one listens to them. So um, we are going to make sure that we figure out where we put you on our website, and in the next newsletter, we'll link to that. And then personally, I think we can think of ways to start using a variety of these videos, starting with the firefighters, but a bunch of the other ones. I also did want to say I really like the ones about what's a social worker, what's the nurses, and then what's a chaplain, who's a chaplain, what do they do. I
Oh
thought,
yeah,
again, those were great. And then the
thanks.
patient centered, I think that's another really interesting idea too. So I'd really like to thank you very much for your time. Thank you for coming and sharing your inspiration with us. And we really appreciate, and we hope we can continue to work with you.
Yeah, no, thanks so much for the invitation and the engagement. It's been wonderful to talk with y'all, and I really appreciate being here.
Good. Well, thank you.